Hi, Dr. Brian Koffman, retired family doctor and a CLL patient myself, the Chief Medical Officer, Executive Vice President, and co-founder of the nonprofit CLL Society. And I'm going to talk about some of the important ASH abstracts that weren't already covered by Dr. Weirda and Dr. Maida, where they were presenting their own research, kind of a smorgasbord, but I tried to organize them in a way that I think will be helpful. And I pick these because they're clinically relevant. They're going to make a difference to us as CLL patients. And you'll see how I kind of theme them. And these are things that you should be thinking about as you go through your CLL journey. So, what new information did I learn? Well, of course, I'm going to talk about COVID-19 and a paper that puts together some other studies into an abstract. I'm going to talk about how we should monitor our response to therapy and how we can use that to guide therapy. I'm going to talk about frontline ibrutinib. I'm going to talk about retreatment with venetoclax. I'm going to talk about acalabrutinib. I'm going to talk about some really exciting new drug combinations, and I'm going to talk about CAR T therapy, specifically around Richter's transformation, one of the great unmet needs in CLL. So let's start with the COVID-19. And this was a worldwide examination of patients with CLL who are hospitalized with COVID-19. And let's just stop right there for a second. These are patients that were sick enough to be hospitalized. So this study looked at 411 patients, and they had the symptoms that you would expect, with the majority having a fever. What's interesting is their lymphocyte counts could be abnormal both up and down. About half had coughing or shortness of breath. And most patients who are admitted to hospitals, you'd expect, needed supplemental oxygen. For those patients who had serious enough disease and were sick enough to be hospitalized, the mortality rate was a dismal 30 to 35%. What the data told us is that it's difficult to predict who has worse odds of dying from their COVID-19. Advanced age plus CLL and comorbidities increase the risk. There was a suggestion that chemoimmunotherapy might also increase the risk. There was no signal that ibrutinib or acalabrutinib helped or hurt outcomes, but that could because for most patients, these drugs were held. But there's a big caveat that I really want to get across. And before everybody gets depressed about that data, if they're not already depressed, is that it was collected very early on in the pandemic. Treatments are much better now. And it only studied the patients who were symptomatic enough to report to their oncologist that they're having problems and needed to be hospitalized. There's a lot of CLL patients who get COVID-19 but maybe asymptomatic or just mildly symptomatic and never need to be hospitalized. So don't despair. This data is getting better, and it only looks at the sickest of the sick CLL patients with COVID-19. Let's look at another group of therapies, and that's monitoring response and guiding therapies. And I'm going to talk about one that I think missed a lot of people's attention, flew under the radar screen: the clinical relevance of residual persistent and elongated abnormal size lymph nodes by longest diameter in patients with CLL who are otherwise in a complete remission. So what are we talking about? Well, a picture's worth 1,000 words, and you can see there's a plump little lymph node on the left in my camera here, and if you look at it in the other CT scan, CAT scan, you'll see that it looks just like Cheshire Cat Moon, just a very thin line. And if you look very carefully, you can kind of see a blacked out area where maybe the lymph node's been replaced by fat. But if you look at the lengths are pretty similar between those two. And both ones show abnormal lengths, but obviously the lymph node has massively shrunk from left to right. So what did they find when they looked at these patients with these residual persistent nodes? There was 1,116 patients, and they looked at multiple phase 3 trials. And of those patients, 161 had an overall response that was called a partial remission because their nodes never got back to the IWCL criteria of 1.5 centimeters or less, even though the rest of their exam was completely normal. Their blood counts were normal in all of them, and in the few patients they were able to look at in their bone marrow, they were all negative. All of these patients were in a complete remission except for one small residual node. So what did we find about these patients? These patients continued to have this sustained response that was identical to patients who were in a complete remission, according to all the parameters. So having a persistent node didn't seem to affect their outcome if it was just slightly enlarged. And what they suggested is that there be an adaptation of the IWO criteria to propose to allow hematologists or oncologists to update or override the radiology assessment from partial remission to complete remission based on clinical judgment if all other components of the oncology review, the blood counts, the bone marrow, looking at the spleen, looking at other organs, all meet the complete remission criteria. And that's going to be really important as we move on to the next topic. And this is really of dual interest here, because here we're talking about MRD-driven limited therapy using 3 drugs, zanubrutinib, obinutuzumab, and venetoclax, the BOVEN trial, in previously untreated CLL, chronic lymphocytic leukemia. And what's interesting about this trial is it wasn't a fixed amount of time, but it was determined by when the patients had a couple undetectable MRDs by flow cytometry in the peripheral blood and 1 in the bone marrow. In patients with undetectable minimal residual disease or measurable residual disease down to 10 uh, 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 to the -4th on 2 consecutive measurements, and in the bone marrow stopped their therapy and entered surveillance. And that could take as little as 7 months or as long as 2 years. So each therapy was individualized to the patient. And from what we've learned in the last presentation is that maybe this is a more important matter than residual lymph nodes. So of the 39 patients that were studied in this study, 2/3 had high or very high risk CLL, and a significant percent had deletion 17p and TP53. The side effects were what we'd expect from this combination of drugs, mostly low counts, but some diarrhea and some infusion reactions. They were followed up for a little more than a year, and 92% of the patients, 34 out of 37, reached undetectable MRD, measurable residual disease in the peripheral blood, and 31 out of 37 in the bone marrow. And over 3/4 of the patients were able to discontinue therapy. But the real excitement about this trial is yet to come, because we're going to see how these patients do long term. And I suspect that there'll be a paper at next year's ASH and the years after ASH. But I really like this. This isn't 12 months or 18 months or 24 months. It is a limited duration rather than a fixed duration of therapy determined by MRD. So let's take a look at a couple other abstracts. And while there's a lot of excitement about combo therapies, what about the game changer ibrutinib and when it's used front line? And this is in patients with CLL with high risk genomics. And now we've got 6.5 years follow-up looking at 2 really important studies, Resonate-2 and Illuminate, combining the data. And I'm just going to quickly go over this. And what this tells you is all classes of patients, ibrutinib favored the comparator, which was chlorambucil. No big surprise there. But this is the slide that you want to take a little deeper look at. And what you're going to see here is that patients who were followed in this trial did extremely well, whether or not they had any of the bad markers, 17p deletion, TP53, unmutated IGHV, BRC3, SFB, SF3B1, and so on. All of these, there was very little difference in the response rates between the patients with the bad markers and with the good markers. So what that means is that in up to 79 months of follow-up, patients showed similar progression-free survival and overall survival with or without high-risk genomics, with or without high-risk factors. And it tells us that ibrutinib therapy has really high response rates in all these classes of patients. This may be less true when ibrutinib is used in later lines of therapy, and it's a strong argument for using it front line in discussion with your clinicians. Let's take a look at some other notable abstracts, and let's look at the other drug that's helped revolutionize care in CLL, and that's venetoclax. This is a real interesting study, the Van-Back trial, with venetoclax was retreatment. So there's a lot of people who worried, well, I don't want to use venetoclax because I don't want to use up all my powder, and then what do I do if I relapse after venetoclax? Well, this study looked at that issue. And essentially what they did is look at 25 patients from 13 different centers who had a first line treatment with venetoclax. It included venetoclax, and then relapsed and had a second line treatment of venetoclax, a later line of therapy. And the average exposure in the first time was a little over a year, and they had impressive response rates, almost 9 out of 10 patients. Between the two treatments, the average was only 8.7 months. And the reason for the second treatment in the vast majority was the CLL was progressing. But for some other patients, the reason was they'd switched from MRD negative to MRD positive, not an indication for treatment, but the doctor and patient had a discussion and said, let's step on this while the disease is still in its infancy on its way back. So what was that response rate like when you used Ven after people were relapsing after Ven? Well, it was a very impressive 72.2%. And of the 25 patients that were retreated with venetoclax, 68% rely on the or still remain on their second line of therapy, and only 4 patients have progressed, suggesting that reuse of venetoclax is a very viable option that patients should be considering. So you haven't burnt your bridges by using venetoclax in the vast majority of patients. This is another very famous venetoclax trial, the Murano trial, that actually led to its FDA approval. And it was what they're here is looking at the group of patients that had undetectable minimal residual disease. And this was a fixed duration, not a limited duration therapy. And in the interest of time, I'm just going to remind you of the results, which was venetoclax plus rituximab. And this was used in relapsed refractory patients versus bendamustine and rituximab. And you can see the progression-free survival was very significantly improved, as was the overall survival at 5 years. That's not a surprise. That's not what we're going to talk about today. What we're going to talk about today is what happened at the end of the treatment. So patients had gone through, finished their therapy with the venetoclax and rituximab, and at the end of treatment, EOT, we have looking at 130 patients, and we can see the vast majority, and this is a recurrent theme, isn't it? Undetectable minimal residual disease or measurable residual disease. And if we look at that groups of patients, we find that 3 years after they've stopped therapy, over 60% of those patients have not progressed. And when they do progress, it takes a while for them to progress to where they need treatment, or where the disease becomes apparent. And of the people who reached undetectable measurable residual disease uh, in follow-up, approximately 40% that undetectable measurable residual disease is being sustained. Now, for the other groups that are in here, we don't find as good results. So for the people with low MRD, the results are close to those with undetectable measurable residual disease, but for high MRD or the people who obviously have disease, the numbers aren't nearly as good. Let's take a look at another important drug, and that's acalabrutinib, and we're going to look at on its by itself and with other therapies. This is the ACE-3 trial, which looks at another combination. Have you seen these couple combos? Before we saw zanubrutinib, now we're seeing acalabrutinib with venetoclax and obinutuzumab. And this is the trial design, which essentially randomizes based on the FDA approvals. And the safety data was reassuring, but I'm just going to read the bolded line. There was no major ventricular heart irregularities, no Richters transformation, no tumor lysis syndrome, and no deaths. And only 1 out of 24 patients had atrial fib, though there was some hypertension and some other serious side effects, as would be expected from these three potent drugs. So in summary, the combination of acalabrutinib and venetoclax and rituximab or obinutuzumab, both are monoclonal antibodies, those last two, that can be added depending on where they are in treatment and what the FDA's approval, had the kind of safety profile that we'd expect. There was hardly anyone who discontinued due to an AE, that's an adverse event. Um, and the responses were deep and durable, 92% in the relapsed refractory and an impressive 100% in the treatment naive group. And complete responses were 50%. But as we've learned, we're not so worried about complete responses. We're much more interested in the overall undetectable MRD, and that was 71% overall in the group. And all the patients who had a complete response were undetectable. And the duration of response has not yet been met. So stay tuned as we follow this trial. Let's also look at a pooled analysis of cardiovascular events. And we know that acalabrutinib the hope is that acalabrutinib will cause less cardiac effects than ibrutinib. So let's look at this analysis. And briefly, what this is telling us is that that over time, there are some cardiac events associated with the use of acalabrutinib, and those include some atrial arrhythmias and some hypertension. But the incidence is quite low, as you can see in the, around the 0.2 range for both of these. And there's recent data that just was released, which suggested that the incidence of atrial fibrillation was well less than 2% in a head-to-head comparison of ibrutinib versus acalabrutinib, or roughly a quarter of what we see with ibrutinib, suggesting that for cardiac patients, acalabrutinib really deserves consideration. Let's take a look at some other new drugs. We've already talked about zanubrutinib. Let's look at some other new drugs and combination therapies. And these are drugs that you may have heard of: umbralisib, ublituximab, not the easiest to pronounce, and venetoclax. And this is in relapsed and refractory CLL. And in this trial, we had 40 patients. Over half had received ibrutinib. And we can see that these were high-risk patients. As we looked at the kinds of problems that they had, we can see the adverse events would be as expected. So what are these three drugs? Umbralisib is a PI3 kinase inhibitor in the same class as idelalisib and duvelisib, both of which are approved. Umbralisib is still an experimental drug, not approved, but unlike the other PI3 kinase inhibitors, it's supposed to cause less adverse events in terms of liver inflammation, lung inflammation, and colitis and diarrhea. And indeed, the data does seem to suggest that based on this study. Ublituximab is a monoclonal antibody similar to obinutuzumab or rituximab, and we know about venetoclax already and its potency. So interesting combination, adverse events certainly manageable and encouraging. So here's a way to look at what the responses were, and we can see that in this difficult to treat, high risk group of patients, relapsed and refractory, that by cycle 7, we had a 100% overall response rate. And again, if we look at the CR and PR, the complete remission and partial remission, we see that about 42% of the patients had a complete remission. But what we're much more interested in is that 95% in the peripheral blood had undetectable MRD and 68% in the bone marrow. And that's the numbers that I think we'll be increasingly looking at as we go down the line. Final paper that I want to talk about is a small study out of Israel, and it's on CAR T therapy and Richters transformation, one of the great unmet needs in CLL. And this is a small group of patients, only 8 patients. And as you can see here, the majority of these had DLBCL, or diffuse large B-cell lymphoma, which is generally bad news when you have that problem. But if we kind of follow along that chart, we're going to see that a number of these patients had a CR, or a complete response, but unfortunately a number also had progressive disease. And we can see that the ones that had a complete response, most of those have done very, very well. So let's look at this data in a different way, in a more kind of summarized way. As we'd expect, patients had cytokine release syndrome that required the medications to calm that down, tocilizumab. And so 7 out of the 8 patients, 3 patients had the neurological toxicities you've seen, which was occasionally significant. There was no fatalities related to the CAR T therapy, but there were 2 fatalities related to disease progression. So overall, and we saw that in this chart right here, that 5 out of the 8 patients responded. That's amazingly good results for Richter's transformation, with a complete response, and on PET scans and everything on by day 28. And these patients have been followed up for between 4 and 10 months. 2 patients have gone on to have a transplant. So this is really encouraging data for Richter's transformation. There's a couple things that are a little different about this CAR T. One is that it was made locally. It was, quote, a fresh CAR T. So it wasn't frozen, it wasn't transported across anywhere. It was made in Israel and just sent to the Israeli patients who needed it. So very exciting for Richter's transformation. So what have we learned from ASH? Here's a quick summary of everything. COVID-19 is dangerous for CLL patients. Don't worry about slightly persistent lymph nodes. MRD is probably much more important than a complete remission, and is growingly important in clinical trials and probably in the lab and clinic for patients. Acalabrutinib is associated with fewer cardiac side effects. Ibrutinib continues to work fabulously well as a frontline therapy, regardless of risk factors. There are some really excellent combinations out there: zanubrutinib, venetoclax, and obinutuzumab, venetoclax and rituximab, umbralisib, ublituximab, and venetoclax, acalabrutinib, venetoclax, and obinutuzumab or rituximab. And CAR T therapy is very promising for Richter's transformation. So thanks very much, and I look forward to answering your questions and finding out more about what's important for you at ASH 2020.